Welcome to Mayo Clinic Sleep Medicine Podcasts, a series for physicians, advanced practice providers, nurses, and other health practitioners treating sleep disorders or interested in learning about state-of-the-art advances in sleep medicine and sleep health. I'm your host, Dr. Michael Silber.
And I'm your co-host, Dr. Maitri Juna. We are both consultants at the Center for Sleep Medicine at the Mayo Clinic in Rochester, Minnesota. Thank you all for joining us for today's podcast titled The Diagnosis of Narcolepsy. Where does CSF Orexin fit in? It is now almost a quarter of a century since the discovery of the relationship between narcolepsy and the hypocretin orexin neurotransmitter system. Yet, most patients with a suspected diagnosis of this condition still undergo a multiple sleep latency test, which, as you heard in our prior podcast, can be fraught with difficulties in interpretation. To discuss the role of spinal fluid Orexin-A testing in the diagnosis of patients with hypersomnia, I'm joined today by my guest, Dr. Michael Silber, professor of neurology at the Mayo Clinic College of Medicine and Science, and a board-certified sleep specialist. Mike, thank you for joining us. Let us start off with, what is orexin and why does it have two names? And how is it related to narcolepsy?
Well, thank you, Maitri. Orexin is a neuropeptide neurotransmitter. In other words, it's a peptide chain of amino acids produced in the central nervous system. It was discovered in 1999 by two groups almost simultaneously, and the one group thought that it was related to appetite control, and so they called it orexin. And the other group noted that it was synthesized by a small group of neurons in the posterolateral hypothalamus, hence hypo, and had a vague chemical synergy to the hormone secretin, so that gave the etin at the end, and they called it hypocretin or hypocretin. Both names have remained in place over the years, but I think orexin is beginning to surge in popularity, so I'll call it orexin for the rest of our discussion today, but hypocretin is perfectly acceptable. There are two forms of the neuropeptide, orexin-A and orexin-B, or hypocretin 1 and hypocretin 2, but they're the same. Hypocretin 1 is orexin-A. Well, barely a year after orexin was discovered, two groups of investigators worked out the relationship to narcolepsy. The first group was at Stanford, led by Dr. Emmanuel Mignot, and they had been trying for a decade to find the cause of narcolepsy in their colony of narcoleptic dogs. Now, narcolepsy in dogs is very straightforward in that it is a simple Mendelian autosomal recessive disorder as opposed to humans. And what they discovered was that it was due to absence of the hypocretin or orexin receptor 2 gene. In other words, they could produce orexin, these dogs, but they couldn't bind it to a receptor, so it was ineffective. At about the same time, another group of investigators were looking at hypocretin knockout mice. In other words, they deleted the entire gene for orexin hypocretin, and they were interested in metabolism, but they found serendipitously that their mice were falling down on the floor of their cages as if they were either falling asleep or having cataplexy, which indeed they were. So they had made a strain of narcoleptic mice by removing the entire ligand. In humans, it's a little different. We can measure orexin-A in the CSF of humans with narcolepsy, and it is largely absent, suggesting the cells are not producing it. Now, most patients with narcolepsy thankfully do not die of their disease, so there's sparse autopsy material, but where there is, what has been found is a complete absence of hypocretin synthesizing cells in the posterolateral hypothalamus, and often with some gliosis suggesting inflammation. And this has led to the hypothesis that we are dealing in humans with an autoimmune attack on these cells, destroying them. There's a fair amount of evidence in support of this, but that's another story.
So as you mentioned, human idiopathic narcolepsy is believed to likely be an autoimmune disorder. How is this hypothesis linked to the HLA status of patients? And should we be testing for this narcolepsy associated HLA antigen in everyone with hypersomnia? What is the clinical role in this testing?
Well, HLA DQB10602, quite a mouthful, is sometimes called the narcolepsy antigen, which is a terrible name for it, as you'll hear in a moment. If you have narcolepsy with cataplexy, almost 95%, if not higher, of those patients will be positive for HLA DQB10602. But if you have narcolepsy proven on an MSLT without cataplexy, only 50% of those patients will be positive for DQB10602. In addition, if we just take somebody from the normal population who doesn't have any sleepiness at all, there's a 20 to 25% chance that they will also be positive for DQB10602 because, of course, it's just a normal HLA antigen. So in the absence of cataplexy, it is neither specific nor sensitive. And even in the presence of suspected cataplexy, it's not specific by any means. So it's not a good test for narcolepsy, and we certainly shouldn't be doing it in every sleepy patient. There is an indication for it, a strong indication, which perhaps will, I'll tell you now what that indication is. The fact is that for almost all patients who have low CSF Orexin-A on testing, they will be HLA positive for DQB10602. And if you're negative for DQB10602, the probability that you'll have a low CSF orexin in idiopathic narcolepsy is so low, it's probably not worth doing the CSF. So the one indication for it is if you're planning to do a spinal tap, which is a somewhat invasive investigation for narcolepsy to measure CSF orexin, it's worth doing the HLA first. And if you're negative for DQB10602 in general, we wouldn't proceed with the spinal tap. Now, there are exceptions to that. There's been a recent report from Europe of occasional patients who were HLA negative and still had a low CSF hypocretin, but that was fewer than 2% of their very large total sample. And in many of those 2% or fewer than 2%, the cases were somewhat atypical. So I think the rule still applies. The second exception would be if you're not really looking for idiopathic narcolepsy, but narcolepsy related to other defined autoimmune conditions of the brain, or a structural lesion in the hypothalamus, or neurodegenerative disorders, then you might find low CSF hypocretin or orexin without being positive, because, of course, we're no longer dealing with idiopathic autoimmune narcolepsy. But with those exceptions, I think a good rule of thumb is if you're not positive for DQB10602, there's probably no purpose in doing the CSF.
That's very helpful, Mike, especially for our clinical colleagues. So, could you speak a little bit more about measuring orexin A levels in the spinal fluid? How accurate are those levels when measured, and what should providers be looking for when, what is the cutoff, I guess?
Mhm. Well, if you have sleepiness and what really sounds like cataplexy, there's a 90 to 95% chance that you're going to have a low CSF hypocretin. So very sensitive test. But if you have sleepiness and let's say you've done an MSLT, and there's 2 SOREMs, so it's narcolepsy, but without cataplexy, only 24 to 32%, a quarter to a third of patients will have that low CSF hypocretin. So in the absence of cataplexy, normal CSF hypocretin does not rule out narcolepsy type 2. And similarly, just to get it out of the way, idiopathic hypersomnia patients do not have low CSF hypocretin. Now, how specific is it? It's highly specific. In a large series of patients having CSF done for a range of neurologic disorders, only 2% had low CSF hypocretin, and those 2% included, interestingly, Guillain-Barré patients, another autoimmune disorder, and some with autoimmune encephalopathy associated with high thyroid antibodies. So again, certain very rare situations of other autoimmune diseases that don't look at all like narcolepsy may have low CSF hypocretin. But even if you're taking a population of people with neurologic diseases, having a spinal tap for that, 98% will have normal CSF orexin. In other words, it's a highly specific test when it's positive, but when it's negative, it doesn't rule out narcolepsy type 2. So what is the cutoff? Usually less than 110 picograms per mil is the usual cutoff. There's a gray area between 110 and 200 where some narcoleptics might fall, but over 200 picograms per mil is usually considered normal.
So, if we were to put all of this information together, Mike, what would you say are really the current indications for spinal fluid orexin-A testing? I'm hearing from you patients with excessive sleepiness and a clinical history
Mm.
that is convincing or strongly suggestive of cataplexy. But is there more or other indications that you'd like to share? And I guess my next question, especially for our listeners, is where can this be done?
Well, we start with a patient who we suspect may have narcolepsy. They're whether they have cataplexy or not, they are HLA positive. So that's a good start. We then say, well, should we do this? Well, generally, most patients would prefer a multiple sleep latency test to a spinal tap. So in general, we would do it for somebody in whom a multiple sleep latency test will be difficult to interpret. The first reason and most important one would be they're on medications that are REM suppressant and you can't stop them. In other words, somebody with severe depression, and it's going to be dangerous to take them off for 2 weeks, their antidepressants. Second, somebody who's doing shift work, say, who, they can't take 2 weeks off the shift work to regularize their sleep-wake schedule without losing their job, or terribly sleep deprived for similar reasons, or they've got moderate or severe sleep apnea and they're just not adherent to CPAP, so we've got that as a complicating factor, or very rare, and I don't see these patients, but if they're less than 6 years of age, we really can't do accurate MSLTs. That's rare to have narcoleptics starting at that age, but it does happen. So when it's difficult to interpret the MSLT and you've got a positive HOA, those would be excellent indications. Now, there may well be some patients who say, I just don't want to go through this whole rigmarole of preparing for the MSLT, spinal tap, fine, go ahead. And I think that's very reasonable as well. As neurologists, we're a lot more blasé about spinal taps than perhaps other physicians might be. So it can be done as a first-line investigation anyway, if the patient wishes to go that way. As long as one understands that that if the CSF hypocretin is then normal, it doesn't rule out narcolepsy, and sometimes you then have to work out how to do the MSLT to reach the correct diagnosis. Now, there's one other indication I found somewhat useful in the last few years. I'm sometimes sent patients with drop attacks. Now, all neurologists are very familiar with this conundrum of patients who have drop attacks. Do they lose consciousness? Do they not? And some people will say, is this cataplexy? And, one thinks it should be so easy, cataplexy brought on by laughter, but it's sometimes very difficult. A couple of weeks ago, I had this patient who had these drop attacks brought on by laughter, but also by coughing. Now, cataplexy brought on by coughing, that's very unusual. We went the whole multiple sleep latency test route. It was totally normal, and I think the patient has cough syncope. But just an example that it can sometimes be difficult, and you've got these patients with, is it cataplexy, is it some form of pseudo-cataplexy? They're HOA positive, and I've occasionally done spinal taps just to say, what's the orexin? If it's normal, I can reassure everybody, this is not cataplexy, because if they had cataplexy in this, that would be type 1 narcolepsy, and the CSF hypocretin should be low. So I found that somewhat useful, but it's a rare indication for it. Where can it be done? Well, all I can say is, to the best of my current knowledge, and I may be incorrect, in the United States, only Mayo Clinic is offering it as a clinic or as opposed to a research test. It's very easy to send the CSF. All that's required for an adult is 1.5 ml of the CSF. If there's any red cell contamination, it needs to be centrifuged down and the supernatant sent to Mayo Medical Laboratories, and the test can be found online in our catalog, and it's very easy for your clinical laboratory to send it off to us, and we'll do it for you.
That's very helpful. So really, it sounds like, in summary, the current indications for the spinal fluid testing for Orexin-A are when you really can't interpret the MSLT because they're potential confounders or the patient is under the age of 6, or as you stated, when you're evaluating spells or drop attacks that may be cataplexy. What final messages would you like to leave with our listeners?
I think it's important for everyone investigating or managing patients with suspected narcolepsy to understand clearly the orexin story and to realize that we now have an alternative diagnostic test as opposed to the multiple sleep latency test for the most appropriate patients. But we do all have to understand clearly there are limitations here as well, and that whereas a positive test is almost 100% diagnostic, a negative test, especially in the absence of cataplexy, does not rule out narcolepsy type 2 and certainly doesn't rule out idiopathic hypersomnia.
Thank you, Mike, for sharing your expertise with our listeners today, and for our listeners for tuning in.
It's a pleasure. Thank you. We hope you enjoyed this podcast. If so, please tune in again through wherever you receive your podcasts as we discuss further topics in sleep medicine and sleep health. Thank you.